Welcome to the Clinical Athlete Journal Club number 11. My name is Quinn Hennick, and I'm a proud clinical athlete provider, and I'm joined by Kevin McNamara, a recent physical therapy school grad, clinical athlete forum member, and the one responsible for bringing the journal club to life. He's also at the Johns Hopkins residency program. What's up, Kevin?
Not too much, Quinn. Thanks for joining us on this. Is it Indigenous Peoples Day now, or is it Columbus Day still?
That's a good question.
Anyways,
it says Columbus Day on my calendar. Indigenous people.
We'll stay out of politics and
Okay.
stick to something I'm more comfortable talking with.
All right, you probably just triggered at least two people. It's fine. It's good. I'm gonna get the patellofemoral pain conversation started that way. Speaking of which, that is our topic, the clinical practice guideline paper for patellofemoral pain. And I've made a few poll questions to kind of get to know the audience and pertaining to our topic. So I'm going to launch the first question, as always, our who are you question. So it should pop up in front of you. Are you a clinician, coach, trainer, student clinician, student, coach, trainer? So just give a little click there. Looks like we've got 60% clinician, 20% coach trainer, 20% student clinician. Cool, so a little bit more clinic in the house. And have you ever experienced patellofemoral pain yourself? Yes or no? Kevin, have you?
I've not actually. I've been pretty lucky. I think.
Don't let this meeting nocebo you. I sure as hell have, but it's good. That means you've managed your load very well.
I just don't do anything.
There you go. 80% say yes, 20% say no. Lucky bastards. Have you treated athletes or clients with patellofemoral pain? Yes or no? Kevin? Yes or no?
I would say, let me pull it up here right now, actually, just tracking like my caseload. Right now I'm seeing about 40 to 55% of people that I would classify as like anterior knee pain.
Really? Yeah.
Yeah.
Yeah, I see it all the time too, and so does everybody else. Has 100% say yes on that. No surprise there. And are you confident in treating patellofemoral pain? Yes or no? And that's obviously subjective. What does confident mean? Maybe more confident after reading the practice guidelines. %, yes. All right, got a confident group. 20% no. Kevin, what do you say on that?
I think it depends on the day, man. I've had some kind of blow up on me recently, actually. So, yeah, I don't know. I'd say yes more so than no, but I got one actually that I'm gonna throw a case study up in the forum. Pretty interesting one. So I'm got my data together for that. So I'm gonna make sure and try and upload that this week because I'd like to see everybody's thoughts on it. He's an interesting one.
Oh, cool. Yeah, I would say the same. I'm confident. It's not, gosh, I'd say I'm confident in implementing the things that might have an effect, but the presentations are so variable. I'm definitely not confident in the timeline, or like you said, depending on the day, depending on the person. So it's a tough thing to treat sometimes. Sometimes it's easy or simple. All right, well, let's get to the paper. So this thing was beefy, but it read, I think when you look at it, you open it up, it's like, oh, 95 pages, but it reads faster than that. The title is Patellofemoral Pain, Clinical Practice Guidelines Linked to the International Classification of Functioning, Disability, and Health from the Academy of Orthopedic Physical Therapy, of the American Physical Therapy Association, newly published, and the first author is Rich Willie. He's got a lot of good stuff. You follow him on his website, on Facebook, Twitter. He's a guy that puts out some really good information, especially for runners. And he's the first author with his team here. So, you know, this is a pretty comprehensive piece, just kind of looking at our overall management of patellofemoral pain as a condition. So, you know, gosh, we could start a lot of places here. The first piece of notes that I started to make were in regards to the classification system that they proposed. So I think they do a good job in the beginning of the paper in explaining the levels of evidence and explaining kind of how they classify some of the recommendations. And they even distinguish between what really has no empirical data behind it, but is kind of the expert opinion of the panel. And that is the rating of like a capital F on any recommendation. You see that big F, and that's basically just what the panel says about a particular topic. And the diagnostic criteria that they come up with is relatively simple. The presence of retropatellar or peripatellar pain, reproduction of that pain with knee flexion / loading activities like squatting, stair climbing, prolonged sitting, or anything else that load the patellofemoral joint in a flexed position, and then trying to exclude any other conditions that may cause similar symptoms. So within that, you know, could say just have the patient point, where does it hurt? They kind of show you where it hurts. Maybe you press on the tibial plateaus, or you kind of get your thumb up under the patella a little bit, and they say, oh, yep, you know, right there. You have them do a single leg squat or a body weight squat or a step down. They say, yeah, that recreates it right there. Say, okay, I guess we can diagnose you with patellofemoral pain. And then beyond that, this classification system in which the authors propose 4 subcategories to try to guide the treatment strategies, I guess. And they are overload. So a subcategory of patellofemoral pain of overuse / overload without other impairment. Without other impairment being you weren't able to find, you know, you're just kind of eyeballing their movement, everything lines up, what you would see adequately, you're testing strength and there's no gross deficit. Use check range of motion and there's no gross deficit of, you know, these either hyper or hypomobility. Obviously there's lots of gray and subjectivity there that we'll probably get into, but there is some type of inflection point in their history. Like they tell you that they did a lot of something that they weren't necessarily doing before. So that's this spike in workload without really any other impairment that you're able to find clinically. The authors propose that to be the subcategory of overuse, overload, patellofemoral pain without other impairment. Then there's muscle performance deficits as a subcategory of patellofemoral pain, where you're finding hip and or knee musculature strength deficits, which is interesting because hip weakness was more of what they were kind of determining as a result of patellofemoral pain, not necessarily a risk factor. But I don't want to get ahead of myself, but it's hard to categorize something when it's just a kind of a result of a condition and not necessarily a cause of a condition. But that's another subcategory, is muscle performance deficits, where you get some measurable weakness. And then movement coordination deficit, where maybe you're looking at running, changing gait mechanics with running, or with some type of weight bearing knee flexion, knee loaded movement like a single leg squat or something like that, where you're looking at kind of frontal plane motion of the hip and knee complex. And then the 4th subcategory of mobility impairments, which related to either hypermobility of the foot, they talk about, give some objective measurements for foot pronation, and then hypomobility of various soft tissue structures like the hamstrings, the quads, the gastrocnemius, those types of things, even down to some connective tissues like the lateral retinaculum and the IT band. So I kind of stopped there. Just those classifications, those 4 classifications. Kevin, what were your thoughts on that system there?
I like the system. I would also kind of maybe add a 5th one though, more of a like a psychosocial dominated condition, because I think if you kind of look through the paper, we're seeing that we're not treating this that well, with 70 to 90% have reoccurring or chronic pain related to PFPS. And I think the psychosocial factors can be a huge determinant in kind of like that long-term perpetuation of the pain experience. So I would maybe even classify that as maybe a 5th category, someone who is not necessarily, excuse me, not necessarily showing any real deficits peak torque wise at the quad or hip abductors. Range of motion looks pretty good, but they're just continuing to kind of have pain with running, whatever it may be, any symptoms that are meaningful to them. So I like the idea of the classification. I think in some ways PT is a little weird because you can get such a varied approach depending on who you go see as a practitioner. And I think the CPGs, even though they've come under some fire as to being things like cookbook medicine, etc., I like the idea of trying to establish some sort of common language and common approach to a lot of these conditions that we're seeing. So I like the 4 categories. I think they provide a pretty good framework into how we can kind of proceed with the plan of care. Maybe would add one more, but I think they're good overall.
Do you see them distinguishing how you would treat? I would take like the mobility impairments, for example. That one's tough for me because it's like these impairments that you find, they're not necessarily prospective risk factors, or at least haven't been deemed as such. I mean, if you find somebody with a 45% straight leg raise on the same side that they have patellofemoral pain, technically we put them in the mobility impairments category. Does that mean some of the treatments just kind of tugging away at the hamstring, that type of thing?
Yeah. See, I don't think so. I think if I was going to pick one that I'd like to get rid of in favor of maybe like a psychosocial factor, it would probably be the mobility impairments, because I just don't see a lot of support for that having a role in their pain. Maybe I'm wrong, but I think that's the one where I'm kind of like, I don't really love that. The other ones kind of make sense. The data would seem to support that, but the mobility one, I don't really get it. But
yeah, I mean, I kind of in the same boat. The psychosocial thing is interesting there, putting it as its own category. Do you think, because I almost see, it's like psychosocial category or a psychosocial being more of just kind of an umbrella, not an umbrella, but, interspersed within all of them. Because if it were just that, then your intervention would be just that. Or maybe it's just, and sometimes maybe it is, but typically even an education session would be, it's just a little hot, tissues are a little pissed off, no big deal, I've checked this and that. So you're like talking them off the ledge and you're kind of maybe reshaping expectations, but then you're probably still giving some type of, or maybe not, but typically some type of recommendation from a physical standpoint, like you're addressing workload, or you're addressing some type of behavioral modification, or you're addressing some type of trigger, which kind of assumes that still that mechanical lens is part of the deal. So I guess my problem with the classification systems was just the bucketing of it, to where I just see such a, I don't think this diagnosis is clear enough for us to make these, to have distinctions yet of categories. Like you could be doing a little bit of everything if you wanted to.